public commenters to declare any potential conflicts of interest before delivering your remarks. And our first discusser is Faye Feller, Dr. Faye Feller, Chief Medical Officer from Geron. Thanks for being here, Dr. Feller.
Hi, good morning, good afternoon. Thank you for having me. As mentioned, I'm Faye Feller, Chief Medical Officer at Geron Corporation, the developer of imetelstat. I'm trained as a hematologist specializing in myeloid malignancies and have been working in drug development for approximately a decade. In June 2024, Rytelo, or imetelstat, became the first and only FDA-approved telomerase inhibitor and the first oligonucleotide to be approved in an oncology setting. Since its founding in 1990, Geron has focused on telomerase research and discovery, powered by the Nobel Prize-winning science of early collaborators who discovered the role telomeres and telomerase play in the determination of cell mortality. This led to the development of imetelstat, around which we have built a strong hematologic malignancy development program. Today, we are a commercial stage biopharma company with our first indication in adults with lower risk myelodysplastic syndrome, or MDS, with transfusion-dependent anemia. Lower risk MDS is a blood cancer that progresses to require increasingly intensified management of anemia. Symptomatic anemia associated with lower risk MDS can cause severe fatigue, shortness of breath, and subsequent vascular events, tachycardia, and dizziness. Lower risk MDS patients frequently become reliant on red blood cell transfusions, which have been associated with short and long-term clinical consequences that can reduce quality of life, cause emotional and psychosocial issues, and shorten survival. As an orphan disease, there is low prevalence of patients with lower risk MDS in the US. Red blood cell transfusion-dependent patients, lower risk MDS patients who are relapsed refractory to or ineligible for erythropoiesis stimulating agents have limited treatment options, underscoring the need for novel options. Lower risk MDS patients with ring sideroblast pathology, or RS positive patients, make up approximately 25% of lower risk MDS patients, and after lack of or loss of response to ESA therapy, often continue to experience a high transfusion burden. Patients without ring sideroblast, or RS negative patients, make up approximately 75% of lower risk MDS patients and are particularly vulnerable to poor clinical outcomes. Additionally, irrespective of RS status, approximately 10% of low risk MDS patients are not eligible for ESAs due to high endogenous serum erythropoietin levels. Rytelo is an FDA-approved treatment for adult patients with low to intermediate 1 risk MDS with transfusion-dependent anemia requiring 4 or more red blood cell units over 8 weeks who have not responded to or have lost response to or are ineligible for ESA. It is important to note that both the RS negative and RS positive lower risk MDS patients are eligible to receive Rytelo. The FDA approval is based on the results from the IMerge phase 3 clinical trial, which was published in The Lancet. Rytelo demonstrated long-term and sustained red blood cell transfusion independence, a reduction in transfusion burden, and increases in hemoglobin levels across all lower risk subgroups that were studied. The IMerge trial met its primary and key secondary endpoints, showing a robust and durable response, with Rytelo demonstrating significantly higher rates of RBC-TI versus placebo for at least 8 consecutive weeks and for at least 24 consecutive weeks. 40% of patients receiving Rytelo achieved at least 8 weeks of continuous RBC-TI, compared to 15% in the placebo group. The median RBC-TI duration for these Rytelo-treated responders was approximately 1 year. An exploratory analysis indicated these patients experienced a median hemoglobin rise of 3.6 grams per deciliter. Additional analysis showed that 18% of Rytelo-treated patients, compared to 2% of placebo, experienced at least 1 year of RBC-TI. And for these Rytelo-treated patients, the median duration of TI was approximately 2.5 years, and a median hemoglobin rise of 5.2 grams per deciliter was observed. In the IMerge trial, the safety profile of Rytelo was well characterized with generally manageable short-lived neutropenia and thrombocytopenia, which are familiar side effects for hematologists who are experienced with managing them. The most common adverse reactions were neutropenia and thrombocytopenia, which lasted a median duration of less than 2 weeks, and in more than 80% of patients resolved to less than grade 2 in under 4 weeks. Cytopenias were managed with dose holds and reductions, which are commonly used medication management techniques in MDS patients. To conclude, we believe RYTELO offers patients with lower risk MDS and anemia who are transfusion dependent a much needed treatment option. At Geron, we are committed to this patient population whose lives are greatly impacted by the burden of frequent blood transfusions associated with the disease. Thank you for the opportunity to comment at this venue.
Dr. Feller, I appreciate greatly your presence here at today's event for ICER and CTAF. In fact, I was wondering if any of the CTAF panelists or may have a question for Faye at this time, or even our expert. There it is, Dan.
Sorry, I didn't mean to get in front of line if anyone at CTAF had questions, but Dr. Feller, thanks for your comments. So one of the questions I have, and given that we have already gone through the data indicating that many of the adverse events that did occur during the IMerge trial were managed with dose reduction, do you have plans to study the use of imetelstat at a lower dose moving forward?
Thank you for your question. I wasn't necessarily prepared to answer questions, but I'll try to do the best I can. As part of our post-marketing requirements with after the approval with the FDA, we are undertaking a dose optimization study, and details about that will be aligned with the FDA in the upcoming months.
Thanks. Rita?
Thanks for your comments. I'm wondering, can you tell us how most people with MDS are diagnosed? Like, do they present with symptoms? Is it on a screening, CVC?
I think there are many here who can speak to that as well, but most commonly it is on, these days it's on a routine blood count, or when being assessed for complaints of tiredness, which I think, all of us probably have, and being found to be anemic without a potential source of bleeding or vitamin deficiency.
Thanks.
Bob?
I'm only going to do this because I know I'm not going to get the chance later, but I find the results from this thing troublingly unimpressive for the first telomerase off the mark inhibitor thing, mechanism of action. So I'd really, and I know you're not going to be able to answer this, but I'm going to ask it anyway. What is the next indication that you all are interested in? Because I don't think the moneymaker is here.
I am able to answer that. We are currently running a phase 3 randomized registration study in relapsed refractory myelofibrosis, which is another hematologic malignancy. In this case, it's primarily treated with JAK inhibitor therapy, such as ruxolitinib, fedratinib, pacritinib, momelotinib. These are approved therapies, but once patients fail these therapies, there are no other non-JAK inhibitor approved options. And our phase 3 study is imetelstat randomized against best available therapy with overall survival as a primary endpoint. And we are the first study in this indication to have overall survival as a primary endpoint.
I want to say I appreciate you answering the question. Okay, thank you.
Yeah. We anticipate those results to be sometime in the first half of 2026 or 2027. It's an event-based analysis so that those timelines can shift.
Faye, I have a quick question. Is the FDA encouraging or mandating that you have a long-term registry related to the use of this drug, with some of the concerns of the side effects and the increased death in the small study that led to approval?
A specific registry was not a registry specific to MDS patients and separate from our current database was not part of our post-marketing requirements.
Okay.
But they are aware of all our ongoing studies and our plans, our development plans.
Okay. Last quick question from Jeff.
Okay, super simple. Would you agree or would you not agree with the characterization of, after looking at the evidence, that there might be a small likelihood of a negative net health benefit with the drug compared to placebo? And why do you feel that way?
Having been a provider and a caretaker for these patients and also a drug developer, I've seen different perspectives of the management of this disease, and also from, the burden that patients experience and the frustration providers have with a lack of treatment options, and addition the perspective of what it takes to get a drug approved and all the resources and time that goes into that, and the complexities of getting all that done within the current systems that we operate in. So I personally maintain that having a drug out there is better than not having a drug out there, and that the value proposition is in favor of treatment and betterment of the lives of these patients.
Thank you very much, Dr. Feller, again, for being here and your comments and also your responses for our questions. Our next speaker is going to be Rochelle Mackey, a caregiver. Rochelle?
Yes.
You're on.
Okay. Well, my husband has had MDS. He was first diagnosed in 2011. And in the beginning, there wasn't much of a problem, except that, he looked it up and he was upset. He thought he was going to die in 4 years. So I said, well, we better travel now while we can, and we did. So we went all over. He became blood transfusion dependent in 2014. Before that, he was on Aranesp, and he became blood transfusion dependent in 2014. And then he went on luspatercept. The big problem, and I'm a nurse, so I watch after all his labs. It's very important that patients remind their caregivers to check on their ferritin level so that they can go on a chelation drug. So he's on XJ. Actually, he's on the generic of XJ because that's a very expensive drug. He's on luspatercept now. He's been on luspatercept for about 2 years. And it was working well in the beginning. He was getting blood transfusions about every 5 weeks. Now he's getting transfused about 2 to 3 units of blood a month. He has other problems which MDS complicates. He smoked 2 packs of cigarettes for 35 years, and he has pulmonary problems. He has interstitial lung disease. So between the interstitial lung disease and the low hemoglobin, he's now developed shrinkage of the white matter in his brain. And on CAT scan, they said that it was due to hypoxia. So it's, that's difficult. We are very lucky because we live 20 minutes from an MDS Center of Excellence here in New Jersey. We're 20 minutes from the John Thurr Cancer Center, and they're wonderful. So we go in on a regular basis. And, you know, I watch him. I mean, they keep his hemoglobin above 9. When he went to 8.4, he developed angina. So, you know, that's what we do. And it's really having yourself on a time basis, and you just put on your calendar with us every Monday, or at least 3 Mondays out of 4, we go for a blood draw. He has to have his blood draw the day before his transfusion because he has so many antibodies from so many blood transfusions that it takes over 4 hours to type and cross match him. And then, you know, they call me and we discuss whether he's going to get 1 unit or 2 units of blood on Tuesday. And that is all of Tuesday. It's 5 hours sitting there. This coming Tuesday, he's going to have his Luspatercept. So that's on my calendar. We've become used to it over all these years, and we just work with it. And his other problems have really become more of a difficulty than the MDS. He doesn't have any pain. I don't know if he's going to go on a Myelodysplastic. Right now, his platelets and his white cells and neutrophils are fine. It's only the red blood cells that are affected. So he is 85 years old, and I don't know if I want him to be, you know, open to having an infection. He never had COVID. We both wear masks anytime we go out of the house. We've had 6 COVID injections, and we'll have our 7th in the fall.
Rochelle, thank you so much for your comments. The perspective that you just gave as a caregiver is just amazing, and your husband is so lucky to have you, 1, taking that burden, and 2, also your expertise in his management. So thank you for being here today. Our last speaker is going to be Ashley Moncrief from the MDS Foundation. Ashley?
Hello. You said my name is Ashley Moncrief. I serve as the Director of Patient Care for the MDS Foundation. By way of disclosure, we are a nonprofit advocacy group, so funding for some of our projects does come from pharmaceutical companies. On a personal note, I served as a research nurse specialist for 5 years, and at that time, imetelstat was one of the medications that we worked with. So I'm a nurse by training and have dedicated my career to those with hematological malignancies. Currently, I'm the first point of contact for the nearly 400 new patients, caregivers, and family members that reach out to our foundation each year. So I'm here today to shed a little bit of light on the patient experience and the impact of imetelstat. My motto with this has been that low risk does not equal low impact for those patients that benefit. Anemia is a common presenting sign of MDS, with up to 80% reporting anemia at baseline. Furthermore, approximately 50 to 90% of those with MDS will require transfusions at some point. It's an accepted fact in the hematology community that progressive anemia and increased transfusion burden diminishes quality of life for those patients and can negatively impact prognosis. In a study conducted by the MDS Foundation in partnership with Clinical Care Options, it was noted that maintaining quality of life was determined to be the identified treatment goal of 56% of patients who responded, far outranking the prolongation of life, which was selected by 31% of respondents. Given the importance of anemia management to both quality and quantity of life in MDS patients, the need for medications like imetelstat is clear. In the 2015 to 2023 patient and caregiver survey conducted by the foundation, quotes were collected from those completing the survey. One really stood out to me. So to paraphrase, the caregiver stated that their lives belong to the disease. So take a moment to consider the impact that transfusion dependency has on quality of life. For those who require blood products on a routine basis, their schedule is dictated by lab checks and transfusions. Between lab checks, type-in screens, and the actual transfusions themselves, these patients lose days of valuable time each month, sometimes each week. There is a loss of control that comes with transfusion dependency, which can have a negative impact on mental health. In the survey referenced previously, the majority of patients, 55%, reported feeling isolated and alone. 33% experienced anxiety, 37% experienced depression, and 35% experienced uncertainty. This does not take into account those not comfortable with reporting the mental health impact of the disease. Despite this, 45% of those surveyed remained hopeful. So what helps to fuel this positivity? It's the approval of medications like imetelstat. It provides me with joy to be able to tell patients calling into the foundation there are options now, ones that didn't even exist a year ago. When I first started my career, there were only 3 FDA-approved medications to treat MDS, and ESAs were the only option for MDS-related anemia. Since that time, there have been 4 FDA approvals in the MDS space, and I have witnessed firsthand how the advent of options breeds hope. The task now is to make it possible for new medications like imetelstat to be accessible. I do worry about the financial burden that patients may experience when it comes to novel therapies. During the past 9 months, an average of 7% of those who called into the foundation were looking for financial resources to include copay assistance. While this percentage may seem small, that's 23 patients who cannot afford the care they need. Even one is too much. Now that the medication is a possibility, it is up to us to ensure it can be a reality for those who desperately need it. Thank you so much for the time to speak today.
Thank you, Ashley, for really rounding out for all of us listening today, and for our panelists, the burden of MDS, and from a patient perspective and a caregiver perspective. I think with this in mind, Steve and Sarah, that we'll break for lunch and come on back at 11:50 Pacific time.
Thank you, Ralph.
Okay.
Yep. I think that's appropriate. So 11:50 Pacific, 2:50 East Coast time, and we'll reconvene to do further deliberation and the voting, following which we'll have our policy roundtable. So thank you again to the folks who presented public comments. That's very helpful. See you all at 11:50 Pacific.